Today we've got a special guest, Dr. Emily O'Leary. Emily is an expert working with OCD and has been doing this work for more than 20 years and is the director and founder of OCD Clinic. Thanks for joining us, Emily. Thanks for coming along and sharing your expertise.
Pleasure. It's always lovely to talk to you.
Look, one of the things that a lot of my registrars raise, especially when they're dealing with complex anxiety disorders like OCD, like GAD, is that they just say the exposure therapy stuff doesn't work. People just get worse and the exposure just kind of spirals everything out of control. But you're in there doing this every day.
Yeah.
What are we missing?
Look, I mean, I don't think they're wrong. Like it's a tough therapy, and that makes sense. I mean, if you said to someone, okay, we're going to go and do your worst fear. I mean, that's going to kind of suck. It's really scary. The thing is with exposure response prevention is it's our most effective therapy, right? That's you can't argue with that. So the skill is in how you get the person there. Now, my take on it is that we go to exposure too soon. I really do. And I think that because if you look at a lot of the CBT protocols and stuff like that, they actually introduce it quite soon.
Yeah.
And I've never done that because, and I've tried it both ways, looking, is this like a personality kind of variable? What am I doing? But I feel like if there's around a dropout rate of 60% with ERP, particularly for OCD, and we know it's hard, we really need to put a lot of work into our therapeutic relationship, but we need to do a lot of cheerleading and making sure their mindset is ready. And I don't think we do that enough. It's like, and this isn't an early career psych thing. This is, I think, just generally, because it's the kind of stuff we don't learn a lot of the time until we're in clinical practice. So we jump too soon. Then they get disappointed. It doesn't work. It's a bit disastrous. And then the assumption is ERP sucks.
Yeah.
So I always like to say to our people coming through, take your time. Like if you want to get more bang for your buck, you really have to get them to the point. If you said to them, okay, we're going to go and do this, how confident are you? Like, is it going to be a 6 or a 7? And also the other thing, if we're just going to do subs, is you've got to start little. And you've got to really have their buy-in. And they need to know that you're not going to get them to do anything that you wouldn't do yourself, right? So, and that is fundamentally important because a lot of the time you do carry that responsibility while they're going through their exposures. But I have found that if I do a lot of time on, let's say the cognitive model of relating to thoughts and things don't matter and blah, 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 really hyping that, we're on the same page, everyone's loving it, right? Everyone loves the good psycho ed, and then we're in beliefs and we're doing formulations and it's like, oh man, this is amazing. Wow, it's not me, it's not my thoughts. And it's like, yeah. And then I always say, by the way, over the next couple of sessions, it's probably going to suck a bit. Okay, I'm just highlighting that we've been doing some really good stuff. We're on the same page and we're going to get to nuts and bolts. So there's a lot of priming going on. So I don't start ERP, and I know a lot of OCD therapists are going to go, I can't believe this, Emily. But I probably don't go there until about session 5 or 6.
Yeah,
I do a lot of faffing, which is not great for the Medicare model, but I do a lot of faffing into the point where they are so pumped. So let's bring this on. I'm going to smash it. That's when you get, and ERP's fun. It is so fun.
You're building an expectancy and building a readiness. I want to come back to that in a second. So I want to find out, you call it faffing, but this to me is the expertise that I really want to unpack. So I want to come back to that in a second. But before I do, I want to ask a little bit about, I'm going to use the word therapeutic stance. Me as a therapist, with nearly all of my clients, I do the uncertain thing. I'm not sure. I just wanted to check, am I on the right track? Whereas with my anxious clients, I feel like it's really important that, no, you are not going to have a heart attack. No, you are not going to die of food poisoning. No.
Yeah.
Do you take that sort of stance, or do you take that more equipoise sort of position with your clients?
Look, I think I'm probably like you very much and again, it's reading your client, right? Yeah. And it depends. Like sometimes those clients, you just go, okay, this client needs to take control and they're going to do that. And you kind of let them for a couple of sessions until the guard's down, and then you'll flip it.
Yep.
But by and large, I'm all about that transfer of responsibility. So I agree that in the first part of session, whether it's OCD or another anxiety disorder, I'm kind of very much like a director. You know, my husband would say, you're being yourself. And I'm just like, okay, this is what we're going to do. We're good. Yeah. And kind of like, so it's very much contained and structured, and you've got this, and it's kind of using a lot of that. And then as they start to move, then I'm a flip. And then when they come back and they're like, well, and I'm flipping it back to them. So the transfer of responsibility is on them. But if we're too ambiguous and how does this feel for you, and you're going to drive them bananas because they're anxious. And a lot of time, I'm not doing a generalization. Well, actually, I am doing generalization, but it's more they are coming. It's a big deal for them to come. They're anxious. They've got this weird stuff in their head. They don't know what's going to happen. And your messaging needs to be, hey, I got you.
Yeah, there's got to be that containment aspect.
Yeah, so I've got you. And how you do that is that's when your art and the personality and everything comes through. And it, you know, so I think that's where the nuances come in.
So I'm going to go back to the thing that you said, that you do a lot of faffing, but it sounds like that faffing is really important. What are you doing in that faffing?
Yeah.
Getting the person, and whether it's motivated, whether it's ready, whether it's accepting the model, like what are your goals? How do you know when they're ready, and what are you doing to get them ready?
Such a good question, isn't it? And it's always that mix between art and science, because even when you do Y-box and this and that and your scales, I mean, it can get so much information. A lot of it for me is reading in the room.
Yeah.
Right. So for example, after I do stock standard formulation, I'll introduce the model like, okay, you know, 95% of people have the same types of thoughts as OCD. It's around how you relate it, lots of normalizing, externalizing. If I have a treatment naive person, they're like, wow, really? I'm like, yeah, true. And then we do this a lot of externalizing, and we'll bring in some diffusion. They're starting to get a little bit confident, and I can move quite quickly. A lot of the clients I get, though, come to me hating every aspect of ERP and believing that they're a deviant. I usually deal with what they call sort of repugnant obsessions. And so a lot of the time it's really on, before I can get to that good stuff, I have to go back and fish my way through all of the I hate therapy and therapy sucks and I'm not going to change stuff. And that can be through motivational interviewing. That can be through irreverence. That can be a lot of the time, how am I going to look at this person, really get to know who they are, as in what is going to make you move. Like the fundamental thing is you're stuck. How am I going to get you unstuck?
So there's a big element of, I'll steal someone else's language, I guess Adrienne Wells in the medical kind of world would talk about like socializing people to the model, like getting them into the formulation, and that's an obsession and that's a compulsion. You can see how this is it that kind of stuff, getting them to think through.
It depends on it depends on the client's stage. Like relatively, I think a lot of the time with clients that are relatively naive to the treatment model, the biggest things are, I'm not mad, bad and dangerous, as Rackman would say, and you get that whole like, you know, clouds part moment.
Yeah.
And then it's like the containment stance. I got you. Let's go and do this. It's going to be fun. It's going to be a bit of a hustle, stuff. The ones that are at the other end, it's more about almost like a recorrection or it's very much on the therapeutic alliance. And because I can't get anywhere, they won't touch exposure. Like these are people that just loathe it. So I have to go and address the beliefs or schemas or whatever is happening within that to then get wiggle room.
I was going to ask that question because, again, you're in a similar space. I get a lot of this referrals in children with conduct disorder. They've gone through, a triple P thing. It hasn't worked, and they've got a lot of negative cognitions towards.
Yeah, and they feel like failures.
Yeah. How do you work with people who've had the one treatment failure, the two treatment failures, the multiple treatment failures? How do you build the relationship to convince them to do the same thing over it?
Yeah. It's a really good question. I don't argue with them, for one. So when they have their facts around exposure sucks, I'm like, yeah, it does. Yeah. Treatment's hard.
But here's some exposure.
Yeah. And therapy's really expensive. It is.
Yeah.
We probably should do something because, I am expensive. Yep, fair call.
Yeah.
And so fundamentally, I think probably what I do the most is I separate that person, and it sounds old school, but I separate the person from the disorder, right? In that they're just giving me all these reasons why this is not going to work. And so I'm going to roll with that, and that's all fine. And then I will shift attention back to something that has worked, or something that they are doing well, or some similarity in some goal. Like sometimes I'll just pick something very tangible, like, yeah, okay, well, maybe let's just go back to sleep's really important, right? Why don't we just try and do that right? Or sometimes I'll just let them have a complete barrage on why they hate psychologists and why they hate therapy and why everything sucks. And then I'll let them kind of go and then come back and go, well, what are we going to do though? Because we're kind of here now. And so I think a lot of it for me is in the dynamic around the person. And also I love people like that. I find them so interesting. And because they really want help, but they've been so fundamentally, I don't know,
Had such a bad time.
something about it, and it's so rewarding because I really do, and you can see the fragility in them. And for me, it's around the nuance. And look, to be honest, and I explain it to my people, like, you try this way, you shut down, next one, next one, next one, next one. It's never a no. Because sometimes, clinicians will go, well, I've done downward arrow, I've done diffusion, and I've done 10 skills. I said, yeah, but have you actually just had a chat with them? What do you mean?
Yeah, got it.
I'm like, why are they going to do diffusion with you if they don't actually like or know anything about you, and they don't trust psychologists? Like, who are they as people?
So I'm hearing a really big chunk of it. This is reminding me of a conversation I had with Stan Steindl, actually talking about motivational interviewing and like listening for the change talk and really trying to, roll with the resistance. And do you have a kind of MI thing in your head when you're thinking, or is it
Look, I love MI.
organically?
But I think, look, to be honest, I'm relatively boring. I use ACT, CBT, schema, and MI.
Yeah.
And again, everything will end up in exposure land and a good formulation. And I kind of flick between all of those, depending on what's happening in the room with that person. Yeah. And then I go, look, I'll start something and go, well, what does that mean about you? And blah, 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 down an arrow. And then, when they get really annoyed, and I'm like, oh, okay, right, they're really annoyed now. I can use that feeling. And then I'll jump over there, like, well, I can feel you're frustrated. Is that, So I flick between them. And then I just read their face, like, what are they showing me? And then I also love that your face is like, your face is not congruent with your emotion stuff. And when you actually point out that you're actively looking and listening, because you are, that is one of, I think, the most poignant things is like, but how did you know that? I'm like, your face changed. Chase affect.
It's really it's congruent with one of my theories that having 3 or 4 approaches that you do well is infinitely superior to having 10 approaches that at a very superficial level.
Hey, why do you think I created my clinics?
I can imagine.
I realized my shortcomings. I'm like, you know what? I just want to choose areas that I love. And, there's a lot of layers and complexity. And OCD is a little bit like eating disorders in that you love it or you really don't, But I love this darkness.
I was going to ask that question just as we're sort of winding up here. Why OCD? Why is that the thing that resonates for you? It's a group that I've worked with, but it's never been a group that I've specialised in. What is it about OCD that has always grabbed you?
Well, I fell into it because I started in early psychosis, and I still love that work, but I just felt I probably couldn't do the work I really wanted to from a cognitive view, and my PhD was very much in cognitive appraisal and cognitive processes. And then I met actually a client, it's really around this client who had dual diagnosis, well managed on medication, but just so intelligent, but just so crippled. And the juxtaposition of this is a person that is so smart, and they are saying the most illogical things in the world, and this is just bizarre. And I couldn't put it together. I'm like, but you're not moving, but they want to move. And the stuckness, and like, I think I can do something. And it was around the OCD method and the madness. This is kind of fascinating, but also the fact is when you work with OCD and they get to recovery, it's just a beautiful area to work with because they really want to do well. They get there and you have the most amazing relationships. And then to be honest, you kind of go through the families and the neighbours and the cousins.
Yeah, yeah.
And that as a therapist is just so rewarding.
It's a really compelling argument when you look at OCD, the gap between what a person's ability is and then the level of function that the disorder, for want of a better word, is actually causing for them. I can see that.
Yeah.
Final challenge for you, because I'm aware that a lot of the people watching this video are going to be early career, and some of them are going to be watching this video in particular because they're interested in OCD. If they don't want to spend $50,000 on going off and doing a training course, etc., what is the number one book, video, training thing? What's the thing that they should go and do that's not going to break their bank, but is going to take them furthest along being ready for treating OCD?
Well, naturally, my training. No. There's so many good resources out there. I would actually say you can get really good training on ERP. I actually wouldn't do a training. I would go and listen to some of the awesome people in this field. And one person I think they should go and listen to as a podcast is Reed Wilson. And it's called The Noise in My Head. And he just is an amazing psychologist, and he really talks a lot around mindset and getting OCD to people with OCD to a point where it's like, bring it on, let's fight this. Listen to people like Reed Wilson, Paul Salkowskis. OCD Stories is amazing. I would actually say, you know what? Yes, you've been training all your life as an early career site. Go and listen to these podcasts of experienced people talk about the relationship. And then if it's like, hey, I like this, then go and do it.
Can I put you on the spot? Because I'd heard of Paul Salkowskis for many years until I'd actually been able to read any of his work, because it turned out I couldn't spell it properly. Can you just tell us how we spell Salkowskis when we're looking him up?
Sure. Salkovskis. He's I met him twice at a conference, and the first time literally couldn't talk. He was like, you're so amazing. So he's a great guy. Yeah.
Fantastic. I had this is not my story, but a colleague of mine apparently met Paul Salkowskis for the second time and said, we actually, met before. And obviously it was a slightly awkward moment. And Paul said, this is embarrassing for both of us, which is such a wonderfully English dry turn of phrase.
Yeah, and look, he's got some amazing, he does so many great collaborations. And actually that was where I was heading over there to hopefully work in his clinic before I stopped in Brisbane Vegas and stayed here. But yeah, no, all of those people, have a look. Yeah.
And finally, we'll give a shout out for the value of finding a good supervisor. I had a look recently on findasupervisor.com.au. There's a number of people listed there who have OCD. You're listed on that profile, aren't you? Are you taking on supervisees at the moment?
Probably not. I'm taking on, there's on my website, I've got a couple of areas that I'm focusing on, but I think we're so lucky in Queensland that we have so many wonderful OCD
really good people.
Yeah. And, it really is like there's a heap of them there, but like, a lot of my team are on there. Yeah. And I can vouch that they're pretty talented. Yep.
That's amazing. Thank you so much for your time, Emily. I really appreciate you taking a minute to share your expertise with us.
Thanks so much, Aaron.
Thank you.
Recently, I've had a lot of early career psychologists reach out to me to ask if there are any structured learning programs to help them in terms of their CPD and their supervision. Now, at the moment, myself and my team are only offering supervision for registrars. And if you're interested in that, we offer a complete supervision package at learning.prep.clinic. However, the CPD that we offer, which includes some of the world's leaders in a range of topics, if you just have a look up here at some of the people that we've got lined up, that CPD program is available at a very reasonable price on a subscription model. So if you're interested, go and check out the options at learning.prep.clinic.